All right, so I guess we're going to go ahead and open this up. Welcome everyone to the Renegade Research Roundtable. We're going to be talking today about sleep and breathing mechanics, the effects they have on each other, and on overall fatigue and energy levels. Thank you for joining us. I am Kat Boniface. I am our science coach, our science communicator. I try to help with the active translation. I also happen to be a graduate of Stony Brook University, so I am familiar with the Stony Brook Sleep Lab. Very excited to have Dr. Gold here. We as an organization, Renegade Research, are a patient and caregiver-led, decentralized 501(c)(3) nonprofit focusing on complex multi-system chronic conditions such as ME/CFS, long COVID, long Lyme, et cetera. Within this, we have three areas of focus: research, that should be agile, patient-centered is our goal. Education to increase the number of clinicians that are able to treat us, whether that is within specialties or in general. So that's one of the purposes of today, to get some more information out there. And practical advocacy around barriers to care, because there are many. Our work is made possible by our wonderful team of volunteers, some of whom are here today, who move the wheels of our organization. Most of us have a personal interest in advancing this research and care of these conditions, either due to our own health or to those of our friends and loved ones. To stay in touch with us and hear about upcoming events, please do subscribe to our newsletter, follow us on social media. We will post links for you, including to when we do have talks like this that are available as recordings. We will post those as well. As a nonprofit, our work also depends on donations of all sizes. Of course, you can help fund our work by donating to our funding campaign, also by sharing the campaign with others who can donate, even if you cannot. To raise funds, we also have some affiliate discounts by partnering with companies whose products and service that we have already used and like, that we have seen benefits from. Does not constitute advice on using those particular products or services. As always, discuss with your healthcare team, whoever that is. But if you do happen to use them, please do consider using the discount codes that we have that'll help you and help fund our nonprofit work. We have some various specials available that we'll post on social media and on the website and such. And we can share some of those in the comments if there is interest. We have also recently opened a clinical telehealth service for New York and Maryland, and also medical coaching for patients elsewhere, headed up by John Houghton, our medical director. For more information, you can visit the Renegade Research website and read about it there. We also have, of course, the presentations from past roundtables and such available on the YouTube channel, and today's will also be available there. So you can use those resources to learn more about other topics, whether you're a patient, a caregiver, a clinician, and share them accordingly. So now I will hand it off to Dr. Houghton to introduce today's speakers.
Sure. Thanks very much, Kat. I'm John Houghton. As Kat said, I'm the medical director for Renegade Research. Our speaker today is Dr. Avram Gold, who's an expert in fatigue and has also been the clinical director of the Stony Brook Sleep Disorders Center, Hopkins trained fellow in sleep medicine, and has a expertise not only in sleep and making it better, but also the underlying issues of fatigue and why sleep is needed in the first place. So we're very excited to hear the details and have the discussion. We have Dr. Rama and Dr. Chetta who have joined us as discussants, and Natalie is a patient who's a discussant, and then we have Dr. Tarpara as well. And the plan here is to have Dr. Gold spend about 45 or 50 minutes in discussion in the background and details around the fatigue and sleep part of it, and then have some discussion. And then depending on where the questions go and the discussion goes, there may be some additional specifics around long COVID and a couple of other topics. But we're excited to hear this, and fatigue and reversing disrupted sleep and circadian rhythm is, as we all know, is very, very critical in this space and the care. So why don't you take it away, Dr. Gold? Thank you.
Thank you. Thank you very much. First of all, I'm happy to be here today. It's not every day that I get the opportunity to speak to a group of both healthcare professionals and patients concerning fatigue. I spend my career treating patients with fatigue, not necessarily patients with chronic fatigue syndrome. And what I'm going to do now is to kind of give you some background as to where the symptom of fatigue and sleep disordered breathing overlap. Here we go. And I'm going to start with the myth that sleep medicine begins with concerning the pathophysiology of sleep apnea. I call it the groupthink of sleep apnea. And to do this, I've gotten a screen from a World Health Organization website, and it could just as easily be the first paragraph of any paper concerning sleep apnea, explaining the pathophysiology of sleep apnea. Sorry. So they say obstructive sleep apnea is a clinical syndrome or disorder marked by frequent pauses in breathing during sleep, usually accompanied by loud snoring. These pauses cut off the oxygen supply to your body for a few seconds and halt the removal of carbon dioxide. As a result of this, your brain briefly wakes you up, reopens the airway, and restarts breathing. This can occur many times during the night and makes proper sleep impossible. During the day, you may experience excessive daytime sleepiness, difficulty in concentrating, or headaches. At night, snoring is the most common feature. And this is what 100% of sleep apnea physicians, sleep medicine physicians believe concerning the pathophysiology of sleep apnea, that there's an element of sleep fragmentation, and that gives rise to daytime sleepiness. But this is not necessarily the case. In reality, fatigue is the dominant complaint in sleep clinics. What I've chosen to do here is to take one paper. This one is by Chervin from 2000, and he published it in Chest. Essentially, it's a very simple clinical paper in which he took somewhere between 180 and 200 consecutive patients who showed up with sleep apnea to the University of Michigan Sleep Disorder Center and carefully dissected what their complaints were. And what he found were that patients with obstructive sleep apnea more often report fatigue or tiredness or lack of energy than sleepiness. In fact, only about 25% of his patients called their worst problem sleepiness. These terms are used distinctly and not interchangeably. They weren't making a mistake or mischaracterizing their symptoms. They knew what they were talking about, and they weren't sleepy. They were either fatigued or tired, or maybe they lacked energy. And the choice of term that they used had no relationship with their apnea-hypopnea index, how severe their sleep fragmentation was, or objective sleepiness. And by objective sleepiness, we mean a measurable indication of sleepiness. We use the multiple sleep latency test, or at least we used to make this measurement until insurance companies stopped covering it for quantifying sleepiness and sleep apnea. And I'll tell you a little bit about it very briefly right now. We'll come back to it later. But the multiple sleep latency test is essentially a test given the day after the night a patient sleeps in the sleep lab, having a polysomnogram. The next day, they're given an opportunity to take 4 naps, evenly spaced over the day. The time to fall asleep during those naps is quantified, And the mean value or the median value is taken to be the mean or median sleep latency. And of course, the shorter the sleep latency on a multiple sleep latency test, the more sleepy the individual. And what you see here is that, in fact, 75% of patients coming into a sleep disorder center for sleep apnea complain essentially of fatigue. And now I'm going to move right into a discussion of upper airway resistance syndrome. The reason I'm going here now is that it will begin to explain why I became interested in the somatic syndromes. Now, before we go any further, I used to call them functional somatic syndromes till I began annoying tremendous numbers of somatic syndrome patients. So later on during this talk, I'm also going to discuss the derivation of the word functional, because I think it's greatly misunderstood. But for the purpose of this talk today, you will hear me mention somatic syndromes, and I'm referring to CFS, fibromyalgia, IBS, TMJ, the whole gamut of recognized somatic syndromes, Gulf War illness. So PT is a patient who I saw in 2011. I presented him once already, many years ago, and I had his presentation, so I incorporated it into this lecture. PT is a 34-year-old male. He's being treated by a psychiatrist for post-traumatic stress disorder, chronic post-traumatic stress disorder, which he experienced after his being at the World Trade Center on 9/11. At Stony Brook University, we have a World Trade Center monitoring program. And so I see large numbers of patients who are first responders on 9/11. And they also develop a somatic syndrome related to that. But many of them have post-traumatic stress disorder from that day. Shortly before his referral, he developed labile hypertension, and a psychiatrist thought he should be evaluated for sleep apnea. His chief complaints are snoring, witnessed apnea, restless sleep, with daytime sleepiness and fatigue. He awakens approximately 5 times nightly without difficulty returning to sleep, and he experiences nightmares twice weekly. Now, remember, he has PTSD, and nightmares are part of the constellation of symptoms in chronic PTSD, along with flashbacks when he's awake. His medical history is, I'm sorry, I keep changing the screen here. Medical history is remarkable for bipolar disorder, hypertension, and his medications are Lamictal, lamotrigine, which he's taking for his PTSD. It's also used as an anxiolytic, and hydrochlorothiazide, which he takes for his hypertension. So PT is severely sleepy. His Epworth Sleepiness Scale score is 19/24, or at least he claims to be subjectively very sleepy. And the Epworth Sleepiness Scale is a test of subjective sleepiness, as opposed to the MSLT, which is objective sleepiness. And you can see here, it's the scale is 0 to 24, with increasing value being increasing sleepiness, and he's very sleepy, severely sleepy. And he's also severely fatigued. And I quantify that with the fatigue severity scale in every patient. And his value, it's scored from 1 to 7, with increasing scale score being increasing fatigue. And he's very high. He's 6.5 out of 7. And he has evidence of somatic arousal. And somatic arousal is something we'll talk about in great detail later. But essentially, it is the physical manifestations, the physical symptoms of increased sympathetic tone. Uh, so, and I'll detail it later, but for now, it's enough to know that it's scored from 17 to 85. There are 17 items that we ask about, and they're rated from 1 to 5. So if you have a score of 52 over 85, you have a very high level of sympathetic tone that you can actually feel as symptoms. And this is not surprising in a patient with chronic PTSD. Part of having an anxiety disorder is to have symptoms of increased sympathetic tone, even when you're not feeling anxious. Now, the PT has a normal affect. He's a relatively lean man. He's 5'11", 191 pounds. BMI, body mass index, is 26, 27. So he's either a little bit overweight or maybe just very muscular. His upper airway, when you look in it, reveals a high-arched, narrow, hard palate with an elongated soft palate and an elongated uvula. And his isthmus of the fauces, the passageway between the mouth and the throat, is narrowed with 1+ tonsils. His Mallampati score is 3, and we'll talk about the Mallampati score in a bit. His collar size is 16, which is kind of an average collar size. His blood pressure is 118 over 80. Remember, he's on an antihypertensive. And his pulse is 76, which is maybe slightly fast for a male at rest. So let's talk about what the anatomy of sleep disordered breathing can look like. And what I'm going to show you now is one of the most typical appearances of sleep disordered breathing. Let's start with the top right. This is a woman from the Far East. She has relatively close set eyes. She has a broad face, as is characteristic in people from the Far East. And she has a narrow nose, narrow nostrils. If we look, and probably also a receding chin, but it's not easy to see in looking at her from the front. But if we look to the side here at this woman, where we have a profile, we see that she has a recessive chin, a receding chin, right? So this goes with the narrow nose and the close-set eyes, a receding chin, and probably she has one also. And this brings the tongue, which is attached right to the back of the chin, closer to the back of the throat. And here, we're looking again at the same thing, close-set eyes, narrow nose, narrow nostrils. But here, this is very interesting, because when a person has narrow nostrils and narrow nose, they have increased nasal resistance. This woman who's at rest has her mouth open, and it's very likely that she's breathing through her mouth. And if you look at her teeth, you see something that looks, and I don't know how clearly you can see it, but we'll see more of it in a bit, a little bit like beaver teeth. She's got her 2 central incisors right here, and her lateral incisors, the next 2 teeth over, are not sitting alongside them. So you see 4 teeth in a row. They're a little bit behind them. And this is telling you that her upper dental arch is very narrow. So the floor of her nose is very narrow. She has increased nasal resistance. And this anatomy is caused by increased nasal resistance during childhood from enlarged adenoids, hay fever, allergies. What happens then is that when the child goes to bed, they open their mouths to breathe through their mouths. The tongue moves away from the upper teeth, and the muscles of the face push their malleable face inward, and they develop this narrow, high-arched palate. And because their mouth is open all night long as they breathe through their mouth, their maxilla, their midface is allowed to grow downward. And now their lower face becomes elongated, their mouth is open much of the night, and their chin actually moves backward. Their jaw becomes short, a shortened jawline, their chin moves backward, and now their tongue is closer to the back of their throat to facilitate sleep disordered breathing. Unless anybody think that I've got something against young women, here's another individual with close-set eyes, narrow nose, right? Somewhat receding chin, and a narrow maxillary dental arch, okay? Who happens to be up at 3:30 in the morning because he can't sleep, tweeting. If we look at the roof of the mouth, this is what we're talking about in terms of a narrow, hard palate. So here it is, very narrow. And here we're looking at the incisors, right? You saw on the woman with her mouth open, you see that the lateral incisors, the two teeth next to the central incisors, are already moving back, and they even move in behind the central incisors when this becomes very narrow. Here you see the narrow nose, slit-like nostrils. Here are the slit-like nostrils. Very narrow nasal passages. And here when we look in the mouth, we see the low-hanging soft palate and the elongated uvula. This is very common. If a person has fatigue and this anatomy, I'm pretty certain we're going to find sleep disordered breathing. Now, we were talking about Mallampati scores. The Mallampati scale was developed by an anesthesiologist who used it to classify how difficult it would be to place an endotracheal tube through the mouth and into the trachea of a patient who needed to be put on a ventilator. Class 1 and class 2, we don't see much in sleep disordered breathing. Class 1, you can make out the entire uvula. Class 2, you make out the base of the uvula, but it disappears behind the tongue. In class 3, you can't make out the uvula at all, just the soft palate. And in class 4, you can't even make out the soft palate, just the hard palate. Class 3 and class 4 are typical of the crowded airway of the sleep apnea patient. PT's polysomnogram was performed in August of 2011. He slept for only 5.5 hours. Normal sleep in a sleep lab is at least 6 hours. Took him about 25 minutes to fall asleep. That's still within the normal limits. We consider anything less than 30 minutes to fall asleep in a sleep lab is normal. He had increased stage 1 sleep, increased light sleep, decreased REM sleep, but his apnea-hypopnea index was 4.7. And in the world of sleep medicine, if your apnea-hypopnea index is not 5, you don't have sleep apnea. Now, I don't agree with this, but this is the groupthink of sleep medicine. And in fact, Medicare will not allow a 65-year-old to have CPAP if their apnea-hypopnea index is 4.7. It must be 5, even if they're very sleepy and they snore. On the day following the polysomnogram, an MSLT was performed, and we were still doing them back in 2011. And on the 4 naps that PT was given, he fell asleep in 6 minutes, 9 minutes, 12.5 minutes, and 18.5 minutes for a median value of 10.8 minutes. Anything less than 8 minutes is considered unusual sleepiness. So at 11 minutes, PT was not objectively sleepy, despite his Epworth sleepiness scale. And we'll talk more about what that means a little later. We then subsequently did a nasal CPAP titration and found that 6 centimeters of water pressure through a nasal mask would hold his airway open so that we could treat him. Now, let's talk about what his sleep study looked like. And before we talk about PT, I'm starting by showing you a case of severe obstructive sleep apnea. This is a polygraph recording on paper of a patient with very severe sleep apnea. It's 2 minutes of sleep. So we cannot use the EEG or the electrooculogram recording eye movements to tell much about the brain waves, but we can tell whether a patient here is asleep or awake by looking at his EMG of the chin. These are superficial electrodes pasted on the chin of the patient, and they're picking up activity of the facial muscles, but just as importantly, the genioglossus muscle, which is the major muscle of the tongue. And when the activity is high, the patient's awake. So we see 4 periods of wakefulness, each lasting, these are 5-second markers, so each lasting about 10, 15 seconds. And then we have these areas where the patient is asleep for about 30 seconds each. There are 3 of them on the page. And lo and behold, if we look at airflow, we see that during sleep, the patient has no airflow. He's apneic. And since we have 3 of these in 2 minutes, that means we have 1.5 in each minute. And since there are 60 minutes in an hour, the patient has an apnea-hypopnea index of 90. This is very severe sleep apnea. Now, looking at airflow, so that you understand what you're looking at, in our lab, airflow is downgoing. Inspiration is downgoing. And during this period of wakefulness, when the patient is breathing in, and then upward is out. In, upward is out. For those of you who have seen sleep studies where inspiration is upgoing, you may wonder, why am I different? And I was trained as a pulmonary physiologist. And in pulmonary physiology, by convention, exhalation is upgoing and inhalation is downgoing. Any one of you who's seen a flow volume loop, if you are practicing physicians or nurse practitioners, if you've seen a flow volume loop, exhalation is always upgoing. In a spirogram, exhalation is always upgoing. And that's the way it is here. Does it make any difference? Absolutely none. So what we see is during sleep, we have apnea. During wakefulness, we have breathing. And if we look at effort, we see that in each one of these apneas, there's an initial period of at least 6 seconds with no inspiratory effort. These are belts placed on the chest and abdomen. And then the patient makes effort to breathe, but has no airflow. And these are termed mixed apneas. There are 3 mixed apneas on this slide. And each one is associated with an oxygen desaturation. The hemoglobin is becoming desaturated from the low 90th percentile, maybe 93 percentile, down to about 85% saturated at the end of each apnea. And you'll notice the nadir saturation occurs approximately 20 seconds after the patient starts breathing again. At this point, the air is being oxygenated in the lungs. It has to come back to the heart and be pumped to the finger where the pulse oximeter is recording it. So the nadir isn't reached for about 20 seconds after the apnea ends. But this is PT. PT doesn't have apnea much. He has 4.7 an hour, not 90 an hour. So you have to look hard to find them. What he has instead is inspiratory airflow limitation. And in inspiratory airflow limitation, what we see is that there's an initiation of inspiration throughout the page. PT starts to breathe in, and then immediately his airway collapses and his inspiration plateaus, or in this case, it even falls back towards 0. And this goes on with each breath, except during 2 periods, a very light arousal here and a much heavier arousal here. During the light arousal, you'll see the EMG activity is picking up. This is 90 seconds now, not 2 minutes. But you see that when there's an arousal, he has deeper breaths and more narrow breaths. Here, you see a very deep breath and very, very narrow with good airflow, right? But here, during inspiration, these are collapsed. This is a collapsed airway with flow limitation, very limited flow, and a wide inspiration so that he has more time to take in as much air as he can. Now we have a microphone on the trachea here, and you're seeing that in these 4 breaths, lo and behold, there's snoring. But what about all these breaths? Aren't these flow limitation? I mean, do these breaths look different than these breaths? Not really. And yet there's no snoring. So does one have to snore to have sleep disordered breathing? Well, now you know. You don't. You absolutely do not. And so a thin woman who doesn't snore and her husband swears she doesn't snore can have inspiratory airflow limitation and nobody would know. And just so you see that PT can snore, here he is, and here are all the breaths, pretty much, except for the last 2, have snoring associated with them. And finally, this is also inspiratory airflow limitation. And this, what makes this flow limitation? I mean, do you see plateauing? And the answer is, yeah, you actually do see a little bit of plateauing. You see widening of the inspiration. And when you actually look at a respiratory cycle, which begins with an exhalation and then terminates with an inspiration, so 1 breath out, 1 breath in, the actual time that inspiration takes is more than a third of the total respiratory cycle. Normally, it takes about a third of the entire cycle. Exhalation takes 2/3 of the cycle. But once inspiration takes 40% of the cycle or more, that's inspiratory airflow limitation, whether or not inspiration plateaus. Now, nobody knows this in sleep medicine. And for that reason, they're busy counting apneas and hypopneas. They don't talk about flow limitation. They don't look for flow limitation. They don't count respiratory effort-related arousals. And this, they certainly wouldn't recognize as anything but normal breathing. And this is why so little of the fatigue that is present in society gets properly diagnosed. ET returned for follow-up 2 weeks after beginning nasal CPAP. His sleepiness and fatigue were both dramatically improved. His symptom of anxiety had abated. Now, let me say that again. His symptom of anxiety had abated. He no longer was experiencing nightmares. So what I'm telling you is his PTSD was going away. And his somatic arousal had decreased dramatically. That was the body sensation questionnaire score. His improvement at the time that I gave this lecture for the first time had persisted for 4 months. His objective compliance with nasal CPAP was 6 hours a night. He was no longer taking hydrochlorothiazide for hypertension, but he remained on lamotrigine, Lamictal, for his anxiety disorder. And here are the actual values of his questionnaire scores. And let me point something out to you, just so you see this. I do this with every patient. No one in sleep medicine does this. Nobody's quantifying fatigue. Nobody's quantifying anything except maybe Epworth Sleepiness Scale on the first visit. This is very unusual, and you'll see why I do it later on. So anyway, body sensation questionnaire went from 52 to 22 and just remained there for the next 4 months. Here's the fatigue severity scale. Fatigue went from severe to mild to moderate to absent fatigue in 4 months. And let's forget about the Epworth Sleepiness Scale, since there's a real question as to whether this person is sleepy at all, ever was sleepy. It turns out that subjective sleepiness is sensitive not only to objective sleepiness, but also to fatigue. And what you're really seeing here is the fatigue severity scale being reflected by the Epworth Sleepiness Scale. This sleepiness that PT perceived that he didn't objectively have was being caused by his fatigue. It caused him to think he was sleepier than he was. So now, where do we go from upper airway resistance syndrome? Well, I began seeing upper airway resistance syndrome about 30 years ago in the mid 1990s. And about 2000, I came over to Stony Brook University from the VA, where I was spending all of my time. And I began to see patients in the Sleep Disorder Center at Stony Brook. And there, I noticed some unusual things about upper airway resistance syndrome patients. That is that compared to obstructive sleep apnea patients, they were younger, leaner, and more often female. And I thought I noticed a lot more insomnia in them, depression, migraine headaches, gastroesophageal reflux, and bruxism, tooth grinding. And so now we're starting to see some symptoms here of somatic syndromes. I didn't know what the somatic syndromes were at that time. But then, this is the part that floored me. I began to see alpha delta sleep. Now, alpha delta sleep, which is represented over here, is a combination of an alpha rhythm that we see on a polysomnogram during relaxed wakefulness, when a patient is sleeping, or not sleeping, awake, with his eyes closed and just relaxing. We see this 8 to 12 cycle per second pattern. These are one centimeter distances. So 8 to 12 cycle per second. And this is a paper speed of about a centimeter per second. They look like the teeth of a comb. In contrast, during the deepest non-REM sleep, we see delta waves. And these are high amplitude, low frequency waves, right? Which indicate the deepest sleep. So we have wakefulness together with sleep, one superimposed upon the other. And that is alpha delta sleep. And it was described first by Harvey Moldavsky in 1975. He was a psychiatrist who had an interest in fibromyalgia. And he noticed this alpha delta sleep. He also was a sleep physician, and he noticed it in fibromyalgia patients. And he described it as alpha intrusion into delta sleep, which creates a state of light, non-restorative sleep. He was speculating that the alpha delta sleep was causing the non-restorative sleep. And he said it represents an internal arousal mechanism disrupting deep sleep despite no external stimuli. Nothing is waking this patient. This patient is just internally awake while the patient is sleeping for reasons that are unknown. The disrupted sleep architecture can generate pain, fatigue, and cognitive symptoms. And there was experimental induction of light, non-restorative sleep in healthy individuals, and that's been shown to cause fibromyalgia-like symptoms. So disrupted deep sleep cause heightened pain sensitivity, giving rise to the fibromyalgia phenotype. That was what Moldavsky thought, except now I was seeing it in UARS patients who were not in pain. But something occurred to me, and that is, and now you've seen what traditional sleep apnea looks like: wake, sleep, wake, sleep, wake, sleep, with breathing, apnea, breathing, apnea, breathing, apnea. But in PT, you saw this consistently obstructed form of breathing. So he wasn't quite breathing like he was awake, and he wasn't apneic. He had inspiratory airflow limitation. And it dawned on me, maybe the collapse of the airway is the thing that's triggering the state of alpha delta sleep of internal arousal in patients with UARS. So now they have non-restorative sleep, and they're sleepy during the day, and they're fatigued during the day. But what is it? It's an adaptive response to collapse of their airway. So now they don't have apnea. They can exchange air. And so I thought that UARS and obstructive sleep apnea were two different disorders related to sleep disordered breathing. One in which the patient cycled between sleep and wakefulness, and the other in which the patient had a state of internal arousal, giving rise to insomnia, which I saw in these patients, and also fatigue, which I saw in these patients, and even headaches. So I had to learn a little bit about the somatic syndromes, and I did some learning. I'll start with George Miller Beard, who was a neurologist in Manhattan, who thought he was among the first to discover a disorder he called neurasthenia. And if you look at the symptoms of neurasthenia, they include pain and tenderness, and he described it in various parts of the body, aching of the entire body, profound exhaustion or fatigue, which he recognized could also be episodic. Perhaps that was PEM. Headache. He described sick headache, which is migraine, in the late 19th century. He was doing this back in 1873. Irritable bowels, and that was nervous dyspepsia, he called it. And he included nausea, flatulence, and diarrhea. Cognitive dysfunction, brain fog, insomnia, both sleep onset and maintenance, drowsiness, depression, which he called hopelessness, anxiety. He had a whole list of phobias. And then he had some miscellaneous disorders. So clearly, he was quantifying the symptoms of somatic syndromes. And what he said about neurasthenia is that the various symptoms and signs of neurasthenia can vary between individuals and over time. So one patient can look like a fibromyalgia patient, the other can look like a chronic fatigue syndrome patient, and the other can look like a migraine headache patient. Now, here, watch this carefully. The symptoms of neurasthenia are functional, as distinguished from organic. These are Beard's words. And what does he mean by functional? He means the pathology Hello, did I disappear?
Briefly, yes. We were at Beard's words on functional.
Um, okay. Can you see my screen?
No, you have to share again.
Okay. Let me find my share option. Here we go. Okay. Good. I apologize for disappearing.
Oh, it happens. We know.
Yeah. Now, I'll make sure you're still recording.
Yes, we are.
Okay. So, and finally, what was the reason for neurasthenia? It was known as nervous exhaustion. And basically, Beard believed that the brain was responsible for electrical energy that maintained the functioning of the organs of the body. And in the because man in the late 19th century was engaging in all sorts of cerebral work as opposed to physical work, he was using up all his energy thinking, and the organs of his body were not getting enough energy. And so they were giving him the symptoms, these functional symptoms of um, neurasthenia. Neurasthenia during the 20th century got fragmented by medical subspecialization into the various somatic syndromes. And at the end of the 20th century, the specialists began to realize that all of these somatic syndromes overlapped. And so they once again reunited them into the functional somatic syndromes. In the early part of the 20th century, when psychiatry came along, they began to speculate that these syndromes, who nobody could find a reason for, were um, were actually of psychological derivation. And so the word functional became confused with psychological, whereas it was always intended to mean due to the functioning of the organs. All right. I think I'm gonna stop here for a moment and give some time for some feedback, and then I will pick up and come to the conclusion of this lecture a little bit later.
Thank you very much for your lecture. I just want to frame a couple things and then open it up to some of our panel for comments, and then we can go through questions. So one, I found it particularly interesting that the lamotrigine was used because lamotrigine ends up being a sodium channel blocker and helps to block some of the glutamate release, which as an excitatory transmitter may be involved in a lot of the overactive brain part of this. So that lines up. And then the historical detail of the concept of the organs working, but having a physiologic issue associated with the organs and their ability to work, as distinct from the later terminology decaying into it's all in your head for the patients, which has been problematic in terms of getting to the root causes of the condition. It feels like an important link. And especially lately with proteomics and various genetic testing and other things showing the mitochondria having issues, calcium channels having issues, keeping voltage across various membranes intact, which requires energy and ATP. And so all of this starts to really line up together with what we see, which is a decreased ability to generate ATP state in many of these post-infectious conditions. And would love to open it up for some comments from the physicians and from Natalie on the panel. And why don't we, if people want to either raise their hand or jump in, that's fine. And otherwise, I'll just call on people, go around the horn, and then we'll get to some questions and see where we go.
Dr. Gold, please stop sharing your screen for a little bit. Thank you.
As soon as I can find that.
At the bottom. There should be a stop share in red.
Yeah, no, it's not coming up. Hold on. On Zoom again.
Okay, go ahead, John.
Oh, it's at the top. I'm sorry. So where's my unshare? Stop. Oh, okay. Hold on. There we go.
Excellent.
Great. Thank you.
I was just going to say, Dr. Rama can only stay for an hour. So if we want to hand it over to him and hear a little bit about his clinical experience with some of these patients who have some of these disorders, that would be great.
Great, thanks. Let me see if I've unmuted.
Yep.
So first of all, this was an amazing talk. I have to hats off to Dr. Avram Gold. I am just amazed that you arrived. I've never heard of you before, but I don't really, go into the, anyway, but I'm amazed that
Okay,
you
I'm not
arrived.
offended.
I'm amazed that you arrived at these conclusions. And I believe, with no disrespect, you're a pulmonologist, correct? Or maybe not. I don't know.
Yeah.
But anyway, yeah, exactly. So it's really
I'm
amazing.
I'm a pulmonologist.
Yeah.
Yes.
Yeah. So you arrived at these conclusions on your own, which tells me you're really a free, independent thinker. And as a pulmonologist, which is even more, a little more disconnected, because neurologists are more connected to the brain typically. So I'm super amazed, and I have to, hands off to that. And everything that you said in this talk is like 100% accurate. I've been doing this for 25 years, and my background is I'm trained at Stanford, still adjunct clinical faculty there. I got my private practice, sleep and brain, and that's all I do. I see people all over the nation, all over the world. They fly in, all these symptoms, and they don't know what's going on. And I'm just sitting there basically going over Dr. Gold's lecture with them. I mean, maybe not that precisely that detail, but so anyway, I also just want to say kudos, great job. This is right on. So anyone watching, he's on. And there's only a handful of people like this in the entire world that even think like this. That's the fascinating thing. Like you said, sleep doctors don't
I'm a
think
very
like this.
lonely man.
Yeah. And so
Not
anyway,
anymore. You have your cheering squad now.
yeah. And then the other thing I want to do is just to throw a little bit of homage to Dr. Christian Gimeno. He was the first person to kind of resurrect or bring up the concept of UARS, upper airway resistance syndrome, and he was a trailblazer. But in any case, he is now passed. I also want to say that in sleep medicine and in the PCP world and the regular medical world, the sleep study is it. If the sleep study isn't positive, then you don't have anything, right? And the sleep study is just one piece of the puzzle. First of all, even if you do the sleep study, like Dr. Gold mentioned, who's reading it? Who's looking at it at that analysis? Who's looking for 1 part inhale, 2 parts exhale? No one's doing it. Who's looking for the flattening of the curve? Most of the time, it's computer scored. The same study could be read differently by different institutions. And that's the reality. I actually trust a home watch pat sleep test better than an in-lab test from pretty much any university or any place, because I trust it. At least it's not the best test, but at least it looks for sympathetic arousals, which is a better proxy than most scorers do. I also want to say that, I'm just picking up random pieces, like the alpha delta sleep. We map the brain. A lot of times what I'm saying is the sleep study is just one part of the puzzle. You also want to rank it. Okay, the sleep study's a 4 out of 10. Well, what does the exam look like? Do they have that narrow palate? The narrow nose, the nasal valve collapse, the crooked teeth, the recessed mandible. So you want to rate them on the symptoms, or your sleep study's a 3 out of 10, but your symptoms are an 8 out of 10. Your exam is an 8 out of 10. What's your cone beam CT look like? Do you have like transverse maxillary deficiency based upon the different parameters? Like you can look at the width of the maxilla at the first molar, at the piriform aperture. You can look at the intermolar width. You can look at the delta between the maxilla and the mandible. It should be 5 to 6 millimeters. And you can look at the pharyngeal space in the back. You can look at the fat. You can do ultrasound, look at the fat content of the tongue. You can go into super ultra detail with this, and nobody, we do it, but nobody else does it in the world that I'm aware of, right? And so, of course, the danger of this, and then you can do rhinomanometry, capnography. Like if you don't breathe properly, you don't do that 1 part inhale, 2 part exhale, you often walk around hypocapnic. Dr. Gold, I invite you to go get a capnography. Test it on all your patients. What you're going to notice is that 40% of them are hypocapnic, just panting, right? And that causes cerebral constriction, Bohr phenomenon. They latch on to the hemoglobin and oxygen tighter, and they don't distribute it. They get ADD symptoms. They get anxious. They get insomnia. They get brain fog, and whatnot, right? And anyway, so the point is, you do all of these tests, and then you put together collectively a story based on that. And I mean, the danger is you can call everybody abnormal at that point. No one's going to escape it. But absolutely, if you have one of these syndromes like chronic fatigue, Lyme, long COVID, or whatever, you want to at least explore this side. And, it could either make you a little bit better or it could make you a lot better, and that's the point. But you should not disregard it 100%. Regarding the alpha delta sleep, I just thought that was interesting that you brought that up because most people don't pick up on that. Like we map the brain on everyone. And I always tell my patients, you want the sun in the day and the moon at night. You want alpha during the day. You want to have a robust alpha during the day. Like when you close your eyes and you're calm, you want robust alpha. A lot of these patients don't. They have flat, minimal alpha, but you want heavy delta at night. You want that deep restorative sleep. And it's interesting. Alpha delta sleep is just like what I tell patients. A lot of my patients have poor alpha during the day and high delta during the day. But it's like having the sun and the moon out during the day and the sun and the moon out at night. And it doesn't work that way. That you can't have the sun and the moon out at the same time. They don't have the same effect. You want the sun in the day and the moon at night. Anyway, I didn't want to talk too long. I just wanted to I was listening to the talk. I was fascinated. It's an amazing, talk. And I just wanted to add my 2 cents.
Thank you very much. And really good, obviously really good detail on it. And the idea of I think we're in the infancy of sort of getting an opening up of the brain waves and some of the ability to get a portable EEG and that as at-home devices is beginning to come out in some of the hacker sphere. So I think we all stay tuned as well. And then there are the gamma waves and what does that do in terms of CSF clearance and the 40 hertz and so on. And so thanks for the comments. If you've got to leave, we understand and we really appreciate your time. And if you could stay to hear a couple more, great. And do you want to go next, Dr. Chawda?
Yeah, sure. So great talk. Thank you so much. And thanks, Natalie, for sort of getting everybody together. One of the things is for patients with ME/CFS, they tend to have like an onset, a trigger. And so, this kind of brought to my mind is, did they not have UARS and did they get it at some point? Many patients are hypermobile, and I wonder if after a trigger, their connective tissue gets looser, it starts to shift their anatomy. A lot of them have changes in their skull and C1, C2 anatomy, and then does that kind of shift their upper airways, and then they get UARS because a lot of them have been screened many years ago and don't have sleep apnea. Of course, I'm learning that it's extremely limited, and maybe they don't have sleep apnea, but maybe they always had a little bit of UARS, and it just got that much more worse after that trigger came along.
Do you want me to answer? Do you want me to address
Yes,
that?
I would love to. Yes.
Oh, well, actually, I've written about that. And the short answer is, but just from the lecture I've given already, you see that the anatomy doesn't change. In other words, if you can see sleep disordered breathing in a person's anatomy and their anatomy doesn't change, then they didn't suddenly catch sleep disordered breathing. They always had the same level of sleep disordered breathing that you can measure. What has changed is their response to the sleep disordered breathing. They've gone from tolerating inspiratory airflow limitation to treating inspiratory airflow limitation as a stressor, and that yields because they have sleep disordered breathing every night for 7 hours, 8 hours, they have chronic stress. And so that light switch that switches from I don't care about sleep disordered breathing to I am stressed by sleep disordered breathing flips them from not having the symptoms of chronic stress to having the symptoms of chronic stress. This is all in the next part of my lecture, and that switches them to having various somatic syndromes. And what is the light switch? An acute stress. So being in a car accident, having physical trauma, having emotional trauma, PTSD, having an infection, being in the Gulf when oil wells are burning and inspiring the chemicals. Those are all potential triggers to convert them from not caring about their snoring to caring about their snoring.
And it's interesting. Oh, I'm sorry. Go ahead.
No, go ahead. No, it's fine.
I was going to say if you look at the innate immune system and how it gets activated with the receptors and sensors on the top of the cell and then some inside, what are the toll-like receptors? The DAMPs, the danger-associated receptors, are the 2, 4, and 9 potentially all play in here. So 2 gets turned on when by Lyme, and so Lyme bacteria fit it and fit it well. 4 we think of in general as gram-negative bacteria, but it turns out that RSV, it turns out that 3 spikes together from COVID fit it very nicely, Ebola fits it nicely. And in a fascinating way, mold and microplastics may be associated with it as well. And then 9 is cell-free chromatin and a few other items. And the key connector with 2, 4, and 9 is that inside the cell, they all zero in on the same pathway, something called MYD88. And that pathway goes down and lights up the NFKB or some of the inflammatory pieces that go into the cell start having the cell in the nucleus in their machinery put out cytokines. And then hey, what about what happens in a low oxygen environment? You end up potentially nucleating HIF1, which is pushing, ends up being pseudohypoxia, and that lights up the same pathways. So there's a common pathway of of inflammatory pressure turned on that that it can result in the same endpoint of the cytokines and other pieces coming out, which then can do lots of things. And teasing that out from a systems perspective, hypoxia ends up causing more of this to happen. And these inflammatory items and what we're seeing from the 2.5 micron industrial or smoke particles also they turn on one of the receptors that's sort of involved in this pathway in general. And so there's a place where it all potentially comes together and can say, hey, the body's is it in a build or breakdown state, an M1, M2 white blood cell state, and how does it bounce back and forth? That can start to explain a lot of the underlying what's happening at an energy level and other places. So it's fascinating, the micro and the macro and the different layers, and certainly gets back to the biochem that I know I didn't always listen to and digest so well in medical school, but turns out it probably has a lot of value.
Okay, so I can comment briefly on the connective tissue disorder connection and the hypermobility connection, because that was one thing. I would just say to doctors, like, yes, the narrow high arched palate is common and the recessed jaws and stuff, but I truly believe that you can have obstructive sleep disordered breathing and have great anatomy. And one of the factors there would be the hypermobility or the connective tissue laxity actually contributing to collapsibility of the upper airway. So I'll just share a couple things. There was a meta-analysis showing that people with Ehlers-Danlos, EDS, and Marfan syndrome were about 6 times more likely to have obstructive sleep apnea than the general population. And one of the studies in that meta-analysis that kind of looked at the severity levels showed that it tends to skew towards mild sleep disordered breathing. So in 100 adult EDS patients, 21% had mild, 11% moderate, and 4% severe. So this kind of fits with what Dr. Gold is. I mean, he's going to go more into this. I think we have to hear the next part of the talk to fully understand his theory, but that there's a trend towards mild sleep disordered breathing, and which fits with the inspiratory flow limitation acting as the stressor rather than the apneas being the relevant or the primary relevant factor. And then there was another study where it was a parallel cohort study where they took 100 adult EDS patients and matched them 1-to-1 according to sex, age, weight, and height. OSA prevalence in the EDS patients was 32% and 6% in matched controls. And they determined based on the control data in the study that the impact of the EDS variable on the apnea-hypopnea index was equivalent to an 11 kilogram per meter squared body mass index gain. So I would just say, be aware of that. Like, you truly can have pretty good looking anatomy, but if you have the, connective tissue laxity contributing to the upper airway collapse, you can still definitely have this problem, even if you look pretty good. And then in terms of what Dr. Chetta was saying about changes to the connective tissue after an infection, that's something I've anecdotally seen on Twitter, like people saying that they didn't have hypermobility, or at least much hypermobility, until they developed a viral infection, and then suddenly they could stretch their skin way out. So I don't know what to think of that, but it certainly seems possible that there could be some kind of worsening of the actual connective tissue that happens with. But I definitely think that a lot of people have sleep disordered breathing and are completely asymptomatic. So that's pretty clear. So we have to, factor that in with Dr. Gold's theory. And that's kind of where the next part of the talk, I think, will get in. And he kind of touched on it just now, but the sensitization to the inspiratory flow limitation piece.
And before we get to the other part of the talk, that if Dr. Tarpara, who's a neurologist from Vanderbilt, wants to weigh in, and certainly with a lot of the autonomic piece, the balance between the sympathetic and parasympathetic side, as well as, and obviously vagus nerve is part of that, and perhaps some other observations. This is a fascinating discussion.
Sorry, I'm actually in labor and delivery with my wife right now, so I can't comment too much, but this is a really fascinating webinar, and I wish I could participate more, but I'll have to catch the replay probably. And I hope, this might be like the start of a organization to promote and increase awareness of UARS, because I think in sleep medicine, there are believers and non-believers in UARS, and some people just don't even think about it. And I'm pretty early in my career, and I think this is a pretty big shortcoming of the current standards of sleep medicine. So, that's all I'll be able to say for now. But
thanks and congratulations. And
thank you.
Being a dad is quite an amazing experience. So congratulations and enjoy it and be present for sure. And then if you look in the brainstem where the vagus nerve comes up, and there's a lot of discussion about the vagus nerve being in people doing vagus nerve stimulation and other interventions can help to add parasympathetic tone, the rest and digest, the slow down side, and sometimes that has good effect. That comes in a spot that's up in that it's in the lower part of the brain as it's going down towards the spinal cord, and there a lot goes on there, and it's also where you get some of the laxity up at the C1 in the high cervical area. And one of the things that goes on there is something called the locus coeruleus, which is essentially the norepinephrine gas pump for the brain. And it has projections all around lots of parts of the brain, including some of the some of the steroid producing areas and the endocrine side, and so they're mechanistically, if you have some impaired blood flow in a very, very small area, you can get a lot of this to happen mechanistically. And that area gets some of its blood flow from arteries coming up from the neck, the vertebral arteries, and some coming down from the brain. And so there are some places that have not very good blood flow. So this idea that you end up with microcirculation rarefied and less oxygen through it can play out just from a anatomical and geographic spot there too. Why don't we look at some of the questions? I don't know if anyone else on our team can see them easily. I can squint to them on my second screen, but if somebody can
Kat
grab
and
them, that would be
Kat
great.
and I are here,
Okay.
and Dr. Rama's been in there answering some, so we'll have to go to share his answers and the questions again.
My
But
patient's
yeah,
5 minutes late. That's why, I was just waiting.
Yeah, no,
thank
thanks.
you. That's great. Kat, do you want to pick your questions?
Sure. So I'd actually had to step away for a moment. I had a call with neurology. But I did actually want to kind of loop back around and just highlight one sort of thread that came out of a lot of the discussion. One thing is just that, things like the patient interview versus questionnaires versus objective measures really shouldn't be versus, right? It's the whole picture. Some of them are going to be more sensitive, some of them are going to be more specific, and taking all of that together is super important. That sleepiness versus fatigue, and the Epworth sleepiness scale really also catching fatigue. It's not terribly specific. That's important. It's like having, when a patient feels cold, is it a fever or is it hypothermia, right? We need to have both the objective and the subjective measure. So I think that's super important to keep in mind. And also that point that Dr. Allen made about, it's always worth exploring, when you have a common systemic disruption, because, even if it's not the root cause, treatment of it might help you improve a little bit. And sometimes it helps you a lot. So it's always worth exploring. So, I really wanted to highlight those. And then a question. So we've had quite a few that have been answered, but there was a question actually from Troy here. I don't know. Do you want to come on up and ask, actually? If we can give those permissions.
Working it.
Okay. There we go.
Can I add a comment?
Sure.
So some of the treatments that some ME/CFS patients do well with, such as like stellate ganglion block, limbic retraining, I wonder if there's a way to get the brain to stop getting stimulated, or, like re-bringing it back. And obviously these treatments don't work for everyone, and in ME/CFS, it's extremely heterogeneous what treatment will work for whom. Definitely screening them for UARS and trying, other treatments that go for it. But this thing about where something triggers and the sympathetic system starts to shift, and then we can shift it back sometimes.
It makes sense, and then you've got the underlying with the genetic parts and SNPs, and so somebody might have the MTHFR be a slow methylator, and that can change some of their metabolism. There are so many variables, and but the body may have a limited number of ways that it reacts to. Is it in a inflammatory, I have to protect myself mode, or is it more in a, hey, I'm in more of a time of abundance and I can build new things, I can remodel, and those you can use a shorthand. It's a little bit reductive, but you can use a shorthand of the M1 white cells tend to be more inflammatory and the M2 white cells tend to be more building. But if you only if you don't have the M1 white cells, you can't build because they also create the vascular growth factor. And so in order to grow new vessels, to get new blood in, to get a new supply chain of oxygen into areas that are don't have much movement of it, you've got to get into inflamed a little bit. And it's that balance of the seesaw back and forth. I think we're just learning how to tweak and personalize. So it's a puzzle with an amazing control system in the body that unfortunately ends up causing a lot of grief from a clinical perspective as a patient. So and Troy's done a lot of, who's just come up with a question here, as a citizen scientist, has done a lot of really great work with the nicotine patch, the nicotine program, and has a question. And why don't you go ahead, Troy?
Yes, I have a question about the shortness of breath in long COVID. A lot of the people who suffer from shortness of breath, when they start using the nicotine patch, the shortness of breath disappears. And I assume that it has to do with the effects on the cholinergic system, maybe calming down the limbic brain or something like that, or improving the connection, the triangle between the brain, the lungs, the heart, etc. But maybe these types of diseases are not actually a physical respiratory blockage, but actually more of a central neurological issue. So I'm just curious of what everybody's thoughts are on this.
I just want to add before we get our expert input, not just the cholinergic system, but one of the sort of lesser studied, because it's fairly new, effects as far as specifically the low dose, particularly through a patch or something like that, rather than inhalation. You also get desensitization of TRPA1, one of the sensory ion channels, which I did notice some of the symptoms that Dr. Gold mentioned also happen to overlap with that particular ion channel. So I found that sort of interesting. But I would love to hear if anybody has had experience
And
with
just
that.
if people aren't familiar with the TRP nomenclature, they're channels that a lot of them are related to calcium moving in and out of cells. And if it takes energy to ATP or energy to move calcium, and if that energy production isn't there, you can flood the cell with calcium, and in the process, that's the cell's signal to blow up or have apoptosis. And so when you just dive into this, the layer after layer, you start getting to the place if you're not making enough energy, if you don't have enough oxygen in there to get the good metabolism of the Krebs cycle, and then you're limited. And that limitation can just cause these local cells to be impaired, but still alive. Somebody want to take Troy's question or comments on it?
Yeah, I'll address it. The symptom of shortness of breath. First of all, it's very common. We see it a lot in patients who get referred to the sleep disorder center, that they've already been referred to the pulmonary division for shortness of breath, and they've had a spirogram, and the spirogram is normal, and nobody can find a reason for their shortness of breath. But shortness of breath is one of the items in the body sensation questionnaire. It is a marker for increased sympathetic tone. It's a symptom of increased sympathetic tone. And in fact, when we put patients on nasal positive airway pressure and we bring down their sympathetic tone, and I haven't shown you that except for one patient so far, but when we bring it down, their shortness of breath improves. And so when you're, if I'm not mistaken, Troy, you said you were giving them nicotine. Are you bringing them over to the parasympathetic side of the balance?
Yeah, so I mean,
so
most of it is yet. Yeah.
Yeah, you're decreasing their sympathetic drive. You're pushing them towards parasympathetic, and they're less short of breath.
Mm-hmm. Okay, thanks.
Any other comments before we move on from there?
Well, I was just going to say regarding Troy's question about is it more of a problem with the actual breathing, or is it a problem with the brain? I would definitely say it's a problem with the brain. So I think we should hear the next part of Dr. Gould's talk, because I think that'll help clarify that part of the whole theory. So
That's great. And then we also don't have to choose, is it one or the other, because it can be
yeah,
both and different people can be affected by one and different by the other and end up in a common pathway there where there's an imbalance. So
right.
Yeah. And I really think emphasizing, like, when we talk about the brain, we're talking about the electrical system, underlying that function. And I think that's a very important point that was brought up earlier.
Yeah. I just meant in the general UARS theory of Dr. Gould's, like,
Sure.
is it a problem with the breathing versus is it a problem in the brain? And of course, you have to have the sleep disordered breathing piece, but in his theory, you have the sleep disordered breathing piece, and then you have the brain becoming sensitive to the sleep disordered breathing. So yeah, let's hear that from Dr. Gould.
Okay, so oops, let me get back into that. Okay, so I think to speed things up a little bit, I'm gonna leave off some of the table setting and serve the meal. So rather than talk about quantifying the symptoms and signs of sleep disorder breathing, I'll point out that I did systematically look at UARS against mild to moderate, and moderate to severe sleep apnea, and found that, in fact, yes, my UARS patients had a high level. About 35% of them had insomnia. Headache was common, about more than 50% of them. TMJ and bruxism, about 50% of them. Irritable bowel syndrome was present in about 45%. So it was truly very common in patients with upper airway resistance syndrome. But this is
do you have that? Are you looking at a slide? If so, is it possible to share what you're looking at? And if not, you're being very clear.
It's not being shared?
No,
You're
I
not
see
seeing
it.
it?
I see
okay.
this.
Then
I see the
it's my
screen.
it's my as long as it's there. I'm not seeing it. I think it's a monitor thing on my end. So
Yeah,
as long as it's being projected,
I
that's
can
great.
see
Yes.
it. One
Yep.
thing I was going to say, Dr. Gould, do you want to explain really quick why you would see the inverse relationship between the apnea hypopnea index and some of these symptoms like insomnia and irritable bowel syndrome? Because I think that's important.
Well, the truth is it's not so clear. But one of the reasons for the inverse relationship is that females are much more prone towards these symptoms than males are. And females tend to have lower apnea hypopnea indices with their sleep apnea than males do. So again, I'll get to that a little later. In UARS, 50% of the patients are women, whereas in moderate to severe sleep apnea and severe sleep apnea, about 16% are female.
Okay, do you want to just go back to the previous slide really quickly?
Okay.
Okay, I was just going to say here really quick. So Dr. Gould said it's unclear exactly what could be going on with this inverse relationship, but one of the things in terms of the mild sleep disordered breathing, and again, UARS, women, more common with mild sleep disordered breathing, is that as you spend more time in apnea, which is a complete cessation of airflow, there's less exposure to inspiratory flow limitation because you're spending more time just no airflow at all. So that could potentially be involved here, because the more time you're spending in inspiratory flow limitation, the more time you're being exposed to this stimulus that your brain is reacting to as a stress. Just wanted to throw that piece out there.
You see, you assume I'm going to say what's on your mind, but that's a good point, and it may be true.
And when if you end up in a place where not as much oxygen is getting delivered to the tissues, there are two things that can happen. So you get your pulse ox that's down, but there have been some of the studies, definitely in long COVID and elsewhere, where you can get some shunting of some of the small vasculature, and so the capillary part of the smallest vessels aren't getting blood flow, and so you're seeing a lowered oxygen tension, but it may even be lower in some of the tissues because some of the capillaries are getting bypassed. And when people have done the capillary scopes on the fingers, you can see this little loops of the capillaries change even dynamically during testing or different breathing pathways. And once you get hypoxia in the tissues, mast cells will degranulate. It'll start pushing some pressure towards microclotting, more inflammation, thickens the wall of the vessels, so less oxygen goes across them. And so you end up with these feed-forward loops that once you start getting loss of oxygen in the local tissues, you can keep getting more and more loss, and it self-sustains even when the trigger goes away. So there's a lot of physiology at work here. So why don't you continue forward?
Okay. So here is what I want to show you. This is actually the second study we did in this series. I showed you before that patients with Moldavsky's hypothesis that patients with fibromyalgia are self-arousing in response to something that isn't coming from the outside. But he didn't really have an idea about what that self-arousal could be about. But the question that I asked was, well, is it inspiratory airflow limitation that isn't being recognized? So I found 28 patients with fibromyalgia. 14 of them were a clinical series from my own lab. I'd asked the rheumatologist at Stony Brook to start sending me their patients because I thought I might be able to help them. But I also was found, and that's the word, by Dr. Joan Broderick. And I'll talk about Dr. Broderick in a moment. She's been very important really in my development because she is a clinical psychologist and was doing research in patient-reported outcomes and in fibromyalgia at Stony Brook while I was there, while I'm still there, but while she was there. And she found out from the grapevine that there was this pulmonologist treating fibromyalgia patients. And she thought that was very curious and called me up and asked me what I was up to. And I explained to her what I thought. And she decided she'd like to collaborate. And so she taught me about fibromyalgia, but she also taught me about patient-reported outcomes. And we'll get to that in a moment. And at the time, she was doing a study that involved 14 patients with fibromyalgia. And she said, you know what, I'll order a sleep study for all my 14 fibromyalgia patients. And now you got 28. And you can look for flow limitation in all of them. And we did. And we found 27 of 28 female fibromyalgia patients had inspiratory airflow limitation during sleep. 10 of the 28 denied snoring. And here is one of the 28. And here you're seeing two 15-second strips of continuous sleep from a CPAP titration for this patient. In the first strip, you'll notice airflow, okay? Stage 2 sleep in each case, exhalation upward, inspiration downward. And you see here that inspiration actually takes longer than exhalation. It's over 50% of the respiratory cycle, and it's a beautiful flat plateau. This is classical inspiratory airflow limitation. What differs in this study is that we're not measuring their inspiratory effort with belts on their chest and abdomen, but with a catheter in their esophagus that's measuring pleural pressure, or the pressure inside the chest. And so you're seeing that this pleural pressure is dropping 15 centimeters of water. That's a very high drop in pressure. And with it, inspiration begins, but then it plateaus despite the fact that the pressure driving inspiration continues to fall. That is the definition of inspiratory airflow limitation. You can see the increased driving pressure, and yet flow is a constant, okay? And this is being done at a nasal mask pressure of essentially atmospheric pressure. Here's 0. This is at 1 centimeters of water, just enough to blow out the CO2 that the patient is exhaling into the mask. We then crank up the pressure to 6 centimeters of water, which is a fairly common pressure in UARS for therapeutic. And now all of a sudden, inspiration is no longer plateauing. It's no longer taking up half of the respiratory cycle. It's nice and rounded. Effort has dropped tremendously, and both effort and airflow are moving in the same direction, right? They're moving in parallel. This is the definition of non-flow limited respiration. And this is how you titrate CPAP for a person who doesn't have any apneas or hypopneas. In most sleep disorder centers, if a patient doesn't have apnea or hypopnea, they don't even know what to do with CPAP because their goal is to get the apnea-hypopnea index below 5. But we're starting below 5. So what we do is we titrate CPAP to eliminate inspiratory airflow limitation. And we achieve that at 6 centimeters of water. And now I want to show you something. During this 15 seconds of sleep in a flow-limited state, the patient's heart rate is 72. As soon as she's no longer flow-limited, her heart rate is 60. Same stage 2 sleep. The autonomic sympathetic tone has decreased during the CPAP titration by eliminating the inspiratory airflow limitation. And my 14 patients received CPAP, and very quickly, this is a visual analog scale. Increasing number means increasing severity of the symptom. And what you're seeing is that fatigue, pain, sleep disturbance, and GI symptoms all improved with 3 weeks of nasal CPAP in these 14 patients with fibromyalgia. Didn't go away 100%. And if they stop the CPAP, the symptoms come back.
It's interesting if it potentially begs the clinical question of if somebody looks to potentially be in this state, and given the availability of CPAP and the realities of costs and logistics and everything else, does it make sense to potentially trial somebody with CPAP to see if their symptoms get better without the full sleep study? So if you have a symptom profile, you have an observer noting snoring or not noticing snoring, or maybe you've got watches or other things showing changes in oxygenation or heart rate. Is there a place where a trial potentially makes sense just logistically?
Well, obviously I can't give you a definitive answer to that, but I will say this. Getting used to sleeping with CPAP is an effort. And I think that you need to really, a lot of patients really need to know there's a reason for doing this. And I said that, so I think it's a great idea, but I think, if it were a pill, it would be a hell of a lot easier. Yeah. So I'm going to very quickly talk about Joan Broderick here. The reason I'm bringing it up is because you've been seeing me using a lot of questionnaires. It was already pointed out that that's very unusual for a pulmonologist. Joan Broderick is the person who got me involved in it. And I know that Natalie has been talking to people in Science for Me, and they see the body sensation questionnaire, and they think this crazy pulmonologist has invented some questionnaire and rationale for understanding sleep disordered breathing. I want you to know that the person who's put me up to these questionnaires is one of the best in the world at this subject. Dr. Broderick is a prominent figure in behavioral medicine and health services research. widely recognized for her pioneering work in patient-reported outcomes and self-report science. During her tenure at Stony Brook, she served as an associate professor in the Department of Psychiatry and Behavioral Science, played a pivotal role in the Applied Behavioral Medicine Research Institute. Her expertise centers on how patients perceive and communicate their own health status, specifically regarding chronic conditions. Promise integration. She's been a key contributor to the patient-reported outcome measurement information system, a gold standard NIH initiative designed to provide validated, reliable tools for measuring physical, mental, and social health from the patient's perspective. Her research at Stony Brook focused on the ecological validity of patient-reported outcome scales and their application in coping skills training for arthritis. And finally, her standing as a global expert led to her appointment to the World Health Organization Expert Working Group, where she assisted in revising the international classification of diseases for somatic distress and dissociative disorders. The reason I'm bringing this up is because you're going to hear about the body sensation questionnaire. It was Dr. Broderick who chose that questionnaire for use as an indicator of stress, as a measurement of stress in sleep-disordered breathing. So for Natalie, when she has to explain the questionnaire, it was chosen by somebody who knew what she was doing. What I'm going to go into is a placebo-controlled trial, a sham, oh, wait a minute. It's a controlled trial of treatment for Gulf War illness. It's also a controlled study of inspiratory airflow dynamics in Gulf War illness. So two elements to this. And I'm assuming that most of you know what Gulf War illness is, but when I was looking for a definition to write the grant for this research, I spoke to Dr. Ben Nadelson, a neurologist at the VA Medical Center in West Orange, New Jersey, who is the director of their War-Related Illness Institute, because I was looking for a definition that I could use to apply for a grant for Gulf War illness. And he said to me, Gulf War illness is just chronic fatigue syndrome in a patient who was in the Persian Gulf from 1990 to 1991. So essentially, they are the same illness. And I asked myself, well, if they're the same illness, why'd you have to call it Gulf War illness? Why don't you just call it chronic fatigue syndrome? If they're both syndromes and you don't know what causes either one, how can you tell one is different from the other? That it needs another name. And quite frankly, I asked the same question about long COVID, which is just like Gulf War illness. But in any case, what we found was he took 18 veterans with Gulf War illness in the Gulf War Illness Veterans Registry and demonstrated snoring and inspiratory airflow limitation during sleep with a mean apnea-hypopnea index of 18, which today is thought of as moderate sleep apnea, and with 96% of their breaths during continuous stage 2 sleep being flow limited. At the same time, because we had a grant, we could find 11 healthy veterans of the same war with no fatigue, pain, or cognitive dysfunction. This was the definition that we utilized for Gulf War illness from some of the literature that was already out. They had to have these 3 symptoms and be Gulf War veterans in the registry to be considered to have Gulf War illness. These veterans didn't have any of the symptoms, were matched for age, sex, and body mass index, and they had an apnea index of 3, with only 36% of their breaths during continuous stage 2 sleep being flow limited. So here, presumably, are 2 veterans. Their BMIs at the time we studied them were 30, which means they were already bordering on obese. When they were in the armed forces, very likely they weighed a lot less. And these people were probably just snorers back then. These people had no flow limitation at all, I'm willing to guess. And when they were both put into the Persian Gulf with oil well fires and volatile organic chemicals going into their systems, they became sensitized to their snoring. And these people had no snoring to become sensitized to. And that's how they ended up being Gulf War veterans with Gulf War illness and healthy controls. And then we took our 18 Gulf War illness patients, divided them in half. It turns out one checked himself into one of the controls, checked himself into a PTSD program, an inpatient program. We had to drop him from the protocol. So we only had 8 controls. We had 9 patients receiving active CPAP for 3 weeks, 3 receiving sham CPAP for 3 weeks. Here you're seeing the improvement in the pain visual analog scale, fatigue severity scale, cognitive visual analog scale, what they perceived of their own brain fog, Pittsburgh Sleep Quality Index, and then we had the SF-36 and SF-36 mental component. These are 2 general health questionnaires, and these get better going upward. Okay, the rest of these get better going downward. And I think in just about every case, there was a statistically significant improvement. Here are the p-values up at the top. Here is the percentage of improvement. These are, I'm blanking on the word. They're compared to, it's a comparison of active treatment to sham. So these are, it'll come to me.
And Dr. Gold,
yes.
Some of the people still can't see your slides. Can you try stop sharing and resharing, or is it the end of the slides?
I'll stop sharing.
If somebody is having trouble seeing it and has multiple monitors or has something behind it, you can end up sometimes having a second screen showing behind one of the screens you're looking at. So if you make it smaller or move it over, you may find the slides hiding behind it.
Is everybody able to see now?
I can.
I can.
Were you not able to see before?
I'm sure the recording is capturing it because I can see it.
Okay.
I don't know about the people who couldn't see it before, but check under your windows for other windows. Okay.
All right, I'll move forward. So, well, let's see, not connecting. Okay, so here's the part where stress comes in. My brother is my biostatistician. He's a brilliant biostatistician. He's very interested in the data. And as we were doing this Gulf War illness research, he called me up one day and said, listen, you got to explain something to me. I'm finding something very, very unusual here. And that is that there's this parameter you're monitoring. It's called sleep stage shifts. And the total of sleep stage shifts for the night is changing with CPAP treatment. And what I'm finding is that the degree of improvement of the sleep stage shifts is in proportion to the improvement of the symptoms for the various patients. As sleep stage shifts goes down, symptoms improve. And conversely, in the sham patients, And let me just go back. These patients all got a little bit worse on sham CPAP. Not a lot worse, but a little bit worse. In other words, sham CPAP wasn't a placebo. It was actually an irritant. And their symptoms of fatigue and pain became somewhat worse. And the change in CPAP, so in the sham patients, there were actually more sleep stage shifts as their symptoms got a little worse. He says you have to explain what these sleep stage shifts are and how they relate to the improvement in the symptoms. Because I've been showing you cross-sectional correlations between symptom severity and something like stress, but or treatment. But when you see a change in one parameter move correlated with a change in another parameter, now you're talking about cause and effect. And these sleep stage shifts may have something to do with why the symptoms are getting better. And I said, well, that's very interesting, but I have no idea, what these sleep stage shifts represent. And here I'm showing you one of the patients who got better. And you see during his before treatment study, his non-REM sleep is shifting back and forth continuously between 2 and 3, 1 and 2, 1 and wake. And then he also shifts back and forth between non-REM and REM. But after 3 weeks of CPAP, the shifts are dramatically decreased, and even REM is much more continuous. And this is what my brother was seeing when he was looking at the data. And so I had to go and start learning about what is the significance of sleep stage shifts. But first, let me show you actually for all of the parameters. This one is for pain. Here you're seeing for all the patients, this is the pain visual analog scale before minus after. And since the pain is going down, it's a positive value for both. And here, where the pain is going up, it's a negative value for both. So you're seeing what I mean by a correlation. The R value is 0.51. For fatigue, it's 0.71. I don't have that particular graph here, but you can see pain was one of the least correlated. Fatigue was highly correlated with sleep stage shifts. And so was cognition, sleep quality, and mental health. Okay. So sleep stage shifts per night, I learned, is a reflection of stress. And when healthy humans spend their first night in a sleep lab, they demonstrate increased sleep stage shifts that decrease during successive nights. And this is known as the first night effect. And this was a study by Agnew back in the 1960s. But Ursula Voss, a psychologist at the University of Frankfurt, wrote a longer paper, and I've got the reference at the bottom, in which she described the adaptive value of sleep stage shifts. She pointed out that predator mammals have fewer sleep stage shifts than their prey, unless the prey are caged in a zoo. If you put the prey in a zoo where they're safe, they have fewer sleep stage shifts. And in the ultimate sleep stage shift, the dolphin or the whale sleeps with one hemisphere of the brain at a time. The shift is between hemispheres. Sleep and wake occurring simultaneously on different sides of the brain. And since always one half of the brain is awake, the dolphin or the whale never drowns. It can come up and breathe. So when sleep is potentially dangerous, the response is increased sleep stage shifts. And this then is what we're overcoming. What we're overcoming with nasal CPAP. What is the danger? The danger, presumably, is inspiratory airflow limitation. And for the veterans of the first Gulf War, it didn't used to be before they got to the Persian Gulf. They were all recruited into the Army. They were all serving. None of them were sick. They went to the Persian Gulf. Some of them had inspiratory airflow limitation. Some of them didn't. Presumably, they were exposed to the toxins in the air in the Persian Gulf. The group with inspiratory airflow limitation became sensitized to their inspiratory airflow limitation. The ones who did not become sensitized. They came home. The toxins in the Gulf were gone, but their inspiratory airflow limitation came with them. And now they're permanently sensitized. Well, I'm getting close to the end of my time. I'm going to leave out my discussion of my learning about stress, except to point out that stress is mediated through the hypothalamic pituitary adrenal axis. Hans Selye, who was in my previous slide, really gets the credit for having discovered that axis and really worked out the details in the first part of the 20th century. But what I learned by reading Hans Selye's book, The Stress of Life, which was written for both physicians and non-physicians, I learned, much to my amazement, that all the symptoms of chronic stress are the symptoms of sleep-disordered breathing. When the hypothalamus stimulates the pituitary under conditions of stress with corticotropin-releasing hormone, and the pituitary puts out ACTH, which stimulates the adrenal, it also decreases gonadotrophic hormones, and it decreases, leading to erectile dysfunction found in many men with sleep apnea, and polycystic ovarian syndrome found in many women with sleep apnea. It also decreases somatotrophic hormone, growth hormone. And when kids with sleep apnea have their tonsils taken out, they often undergo a growth spurt. Meanwhile, ACTH stimulates the adrenal, it puts out glucocorticoids, leading to hyperglycemia, and it also, the adrenal medulla, puts out noradrenaline, norepinephrine, and epinephrine, and as well as the locus coeruleus, as was pointed out earlier, points out norepinephrine, and that gets stimulated directly from the hypothalamus. And so we get hypertension, and eventually myocardial infarction, arteriosclerosis, essentially all of the long-term complications of sleep apnea. And so stress is really the mechanism by which sleep apnea does what it does. And inspiratory airflow limitation may very well be the major cause of most of the consequences of sleep apnea, and certainly the fatigue. Going backwards, I guess. And I'll spare you Selye's 31 symptoms of chronic stress. They're the exact same symptoms as neurasthenia. And so I've really just given you this slide, and that is that the hypothesis is that sensitization to inspiratory airflow limitation leads to stress and the symptoms of Gulf War illness, and maybe the symptoms of many of the somatic syndromes. So Joan Broderick decided I wanted to be able to quantify stress in all of my sleep disordered breathing patients, and I've been doing that now for 15 plus years. And here are the items of the body sensation questionnaire. Just so we point this out right away, the shortness of breath is on here. Startled easily, hands were shaky, was short of breath. Third item. So shortness of breath is one of the symptoms of increased sympathetic tone that you can feel. Hot and cold spells, hands were cold or sweaty, a lot of muscle tremors, trembling, shaking, hands were shaky. There's one on this side. Muscles twitched or trembled, felt heart racing, pounding, was afraid I was going to die, dry mouth, right? Trouble swallowing, the globus hystericus. These are all symptoms of increased sympathetic tone, and you don't have to feel anxious to be able to be aware of these symptoms. So the BSQ is a 17-item questionnaire graded from 17 to 85 for the frequency of those symptoms. We've been using it since 2007 at the Stony Brook University Sleep Disorder Center, and it was originally taken from a questionnaire for depressed patients. A group of psychiatrists were interested in determining what component of their depression was in fact anxiety. And so they had an anxious arousal subscale of the mood and anxiety symptom questionnaire. And that was the original questionnaire and its original name. And this was a study that Joan Broderick did comparing healthy individuals to patients with upper airway resistance syndrome, 17 being no, right, the lowest level of symptoms, and 85 being the highest. Patients with upper airway resistance syndrome tended to be above 20 and pretty much in the high 20s as a mean. Healthy controls, and these were rigorously determined healthy patients, were for the most part below 20, maybe one was above, and there was almost no overlap. There was no stress in this group. The group with UARS, all were demonstrating symptoms of increased sympathetic tone. Here was a group of irritable bowel syndrome, thin women with irritable bowel syndrome, and healthy controls. We also did studies of their airflow, but that's not for this talk. And virtually it was the same as an IBS. The healthies were all below 20, with one exception, and none of the IBS patients were below 20, and they went up to 35. So from these two studies, we have the sense that healthy individuals have a mood and anxiety questionnaire, anxious arousal subscale below 20. And this is the body sensation questionnaire. So this is the last thing I'm going to show you, and I'm just about at the end of my time. Let me ask a question. Shall I stop here because I think I've made my case? Or shall I keep going?
I think this is an important topic, and I think if some people want to stay a little bit longer, if you have the availability and any of the others, that it becomes really important to tease out the specifics of cause and effect of here's sympathetic tone changes in the symptoms from it. What are the drivers of sympathetic tone, such as IBS, such as impaired breathing and inspiratory pressure, as you've described, and other ones potentially out there, and which is the cause, which is the effect, which is the correlation, because in this space, there has been an historic tendency to push towards these are anxious patients, and therefore the anxiety is causing the issue. And it's just fixed. It's a psychologicizes what's going on.
I've already shown you making the anxiety better with CPAP.
Totally agree. And one of our other folks before showed it getting better with increasing venous return by doing some stenting in the iliac veins, and there are various ways that changes occur. And Troy and his work shows some with the nicotine patches. People have had good effect, and really, but I think just taking a moment to emphasize that. Symptoms of increased anxiety and symptoms of increased body symptoms can be a sign of increased sympathetic balance, which doesn't mean it's psychological. There can be an underlying physiologic piece that has somebody constantly in the fight or flight state. And there are a number of things that can happen metabolically, and we're talking about a bunch of them here.
Oh, well, that's that. Yeah, I'm on your page. That's what I
Yeah,
believe.
yeah.
I hope you don't think that I'm talking about people being emotionally
No,
upset.
no. I don't think. I think you've laid out a wonderful case of showing getting more air movement happening and with in getting better flow of through the CPAP and getting better oxygenation of the lungs in that case ends up lowering heart rate, giving better lowering the sympathetic load. And it's the no, I think this adds a detail to it in a very positive way. It's more some of the words and the language that have been used in the literature that allows some crossover that ends up sometimes occurring. And it's important, I think, in the community to reemphasize that the more we learn, the more and more this sympathetic parasympathetic balance seems to be a really critical part. And so whatever you can do to lower the sympathetic tone in some ways is maybe helpful in general as layers, just like you can have layers of triggers and issues that might be mold, might be particulate matter, might be cervical instability, might be inflamed microbiome issues in the bowel, and so on and so on. It's not a single, it's this or that you can have collections and layers of as well.
Absolutely.
Okay.
Like even if everybody here is sort of on that same page, making sure that we're emphasizing it as we are going to distribute the information. Especially, as you mentioned, the slippage in functional and how it's been, completely misapplied, in more recent years than it had been originally meant. That's important clarity.
And getting to that point, and your slides back there I think are critical, that the word functional originally meant an organ function involved in the pathology. It did not have a crossover meaning of it's in your head patient, and it didn't have a crossover meaning of I don't know what's going on, so it must be in your head patient versus I don't know is
when
a
maybe
really
somebody
good
just didn't
clinical
read the
answer.
CPAP or the sleep
Right.
study, right?
Yeah. So no, this is a absolutely wonderful and nuanced discussion and set of data and we appreciate your willingness to share it and the effort that you put in over a career related to generating it. So
I was just going to
thank you.
suggest.
And I'm sorry.
Go ahead, Dr.
So this is going to be my last presentation of data. I think we'll get to the end. I actually had more, but I realized I wasn't going to get to do everything in 2 hours. But this should be interesting because it's large numbers.
Yeah.
Okay, the only thing I was going to say you may just mention the actual hypothesis about how the brain becomes sensitized to inspiratory flow diffusion. Because again, I hear people like focusing on the oxygenation aspect and stuff, and that's not really like a big part of this theory. So if you do want to discuss that, the limbic.
Well, it's not because of what I want. I in order to get through it, I didn't bring the slide illustrating the hypothesized mechanism.
Okay.
So it would be difficult to spell out. I'm not a neurobiologist, so the mechanism for the sensitization is a bit of a black box for me. But that there is cross sensitization is very well known in the limbic system of the brain. It's very clear in addiction. A person who is addicted to, a lab rat who's addicted to alcohol is also addicted to cocaine because they cross-sensitize. And since addiction and stress are all mediated by the hypothalamus, it's reasonable to assume that if one becomes sensitized to a particular item as a stressor and goes through a period of a great increase in stress, that at the same time, there might be cross-sensitization to other things, so that if a person becomes sensitized to some toxin in the oil well fires of the Gulf, they might just by chance become sensitized to their own flow limitation at the same time.
Okay, great.
Really
I have a thread. I have a thread on the olfactory nerve limbic system hypothesis on Twitter.
This is another example. Wait, Natalie, this is another example of Natalie trying to get me to say what's on her mind.
No, Dr. Gold, I was just going to say that I was going to put that thread in the chat. So if people wanted to check out the olfactory.
Say it. No, it's a worthwhile.
Okay. Well, in his 2011 hypothesis piece that was published in Sleep Medicine Reviews, he had a whole hypothesis about the limbic sensitization occurring via the olfactory nerve. And the olfactory nerve has been shown in animals and humans to have properties of sensing changes in nasal airflow and pressure. So he kind of based this hypothesis off of Dr. Bell's model of multiple chemical sensitivity, in which she hypothesized that multiple chemical sensitivity patients develop limbic sensitization to chemicals and odorants via the olfactory nerve. And so he developed his olfactory nerve hypothesis of sensitization to inspiratory flow limitation and changes in nasal airflow and pressure via the olfactory nerve. So I'll put that in the chat box, but go ahead.
He knows my work better than I do. Okay. So here, at this point in my life, when we were undertaking this particular clinical series of patients, I believe that UARS and sleep apnea were two different things. UARS, as I told you already, I believed UARS was a response to chronic stress, to inspiratory airflow limitation. And like all good sleep physicians, I believed that sleep apnea was a disorder of sleep fragmentation. So I now had a measurement of stress in all my sleep patients, and I could compare the stress of UARS patients to the stress of sleep apnea patients, and see how symptoms like sleepiness and fatigue were related to either stress or sleep fragmentation. And that was my goal here. So I collected 152 consecutive UARS patients, newly diagnosed, untreated. And then to match with them, I collected 50 consecutive sleep apnea patients, and I defined sleep apnea as an apnea-hypopnea index of greater than 10. And I took 50 from 3 different levels of severity. 50 consecutive patients with AHIs of 10 to 30, 50 with 30 to 60, and 50 with above 60. So this is a very wide spectrum of obstructive sleep apnea patients. And their ages, as I told you, the UARS patients I'd seen tended to be a little younger, and these were. BMI, not surprisingly, UARS were not obese. And then with increasing AHI, level of obesity went up, until with the highest level of AHI, they were morbidly obese. Percentage female, half were female in the UARS patients, and that dropped off to about a quarter in the mild to moderate sleep apnea patients, and then even less than that as one got more severe. AHIs, not surprisingly, AHI of 4 in the UARS patients, 19 43, and 80 in the three groups. Amount of time spent with an oxygen saturation of less than 90%. For the UARS patients, they only spent 4% of their night below an oxygen saturation of 90. So you can't talk about hypoxia with this group. They're not hypoxic at all. And then 10% in the mild group. And once you get it onto severe, it goes up to about a quarter. And then by the time you get to the very severe sleep apnea patient, half the night is spent desaturating. And now we're looking at the Epworth Sleepiness Scale. There is essentially no difference in Epworth Sleepiness Scale in subjective sleepiness between these three groups. They're all equally subjectively sleepy, whatever that means. Fatigue Severity Scale, again, no difference for all four groups. Nothing related to sleep disordered breathing, whether we're talking about oxygenation, and these are big differences, or apnea-hypopnea index, makes any difference to fatigue. And body sensation questionnaire, right? They're all essentially the same. All the same. Again, nothing related to their conventional sleep parameters makes a difference. So I wouldn't bother thinking about hypoxemia or hypercapnia or arousal frequency as the trigger for the stress that these people are experiencing.
Just a comment on that. Certainly the measurement of a PO2 on a pulse ox, and if that is synonymous with local tissue oxygenation in the capillary beds, then that is a very true statement. And I think there's the clarity and specificity of, are the capillary beds oxygenated the same as what is measured on a pulse ox? Get two things happen. One, you can get shunting, and then two, as the body starts breaking down red cells in impaired glycocalyx and small vessels, you start ending up with increase of the clinical measure of the RDW, or ends up saying, hey, blood cells are bouncing on the walls of the capillaries. But when red blood cells break down, the body is producing carbon monoxide in that breakdown as one of the byproducts, which is read by a pulse ox as well as being oxygen. And so and then in some of the there are places in some of the autobrewery functionalities where you can see some of these changes too. So there may be a nuanced measure, and it's clear and awesome that we're seeing give CPAP to these folks, and they're getting better with their clinical symptoms. And it may be that there are multiple triggers where giving CPAP is helping an issue. And just like one of our previous folks would have the same specificity of saying, if you stent the iliac veins, increase blood return to the heart, and you fix all this stuff. And so we try to be careful to call out which areas we know for sure, what are some of the nuances that could be involved in this as we're all learning, and really, really appreciate the specificity that you're able to give us. And frankly, at the end of the day, the clinically showing that people are getting better with CPAP, and a lot of people are. And really, at some point, as patients, people want to get better.
Absolutely, and you know, as you speak, I get that I'm presenting clinical data, so there's room to interpret everything that I'm presenting, because I'm at the macroscopic level. So I'm guessing that, being that I'm measuring the oximetry with a pulse oximeter, which is sensing the blood going through the capillaries, that I'm not too far removed from the tissue, but I can't tell you to what extent, and I don't know why there would be a lot of carbon monoxide in that blood.
This
It's
is
the production.
probably speculative, but I have noticed among patients there is often a sort of a sweet spot, like in terms of that the measure of the pulse ox, where when you have somebody that's like 97, 98, 99, that tends to be their best function, but that same person at 100 often has a decline in function. So I wonder if we just like eliminate the very, very top end outliers, if the picture we get will then firmly just look at oxygen, because it may be that those over readings are representing that breakdown of the cell and release of carbon monoxide in those individual cases where that can happen. But that's speculative, of course.
Yeah, I mean, so in answer to the carbon monoxide piece, when red cells break down, part of that breakdown process produces heat, carbon monoxide, and I think it's bilirubin or biliverdin. But there are three things on the HO1 pathway that occur, and it's not something that we generally think about from a clinical perspective at all. But it potentially kind of ends up in this space, and it's just to keep as a data point, because if you go down like the Pretorius and Kell path of microclots and inflamed capillaries, you end up with a smaller lumen, and so then you have less space for the red cells to get through the smallest capillaries, and as they bump into the walls, because the glycocalyx is rougher because of the nets and all that kind of stuff, or there's a cork in there because the microclot is that cork where the net is, then you end up in a place where you've got more red blood cell breakdown in some areas as well. And I think my statements around this are not dogmatic. It's saying there are different moving parts at different layers, and to make sure that we don't end up knocking those out of the discussion if they might be consistent with the discussion, where, for example, in this case, there would be consistency with bringing more oxygen into the body will it potentially downstream give some areas that are right on the edge of not having enough oxygen would get a little bit more. If you decrease sympathetic tone, you can change the caliber of blood vessels, and that changes blood flow and a whole bunch of stuff, it's a different topic than this, but that none of it's, I don't think any of these are inconsistent with each other, but it's just, when do we make the full cause and effect statement as well, because different people have different sets of background parameters, exposure to environment, and so on and so on.
Shall I go ahead?
Yeah.
Okay. So now here, this slide blew me away when I saw it for the first time. And it's a slide that it looks at Epworth Sleepiness Scale and Fatigue Severity Scale versus the Body Sensation Questionnaire as an indicator of stress in the 152 UARS patients and the 150 obstructive sleep apnea patients. Now, the first thing I'm going to say is I'm going to forget about the top of the screen. And I told you earlier that recently we published a paper that disqualified subjective sleepiness as a measurement that quantifies sleepiness. So I really don't know that this data is anything but sort of a poor reflection of fatigue data. But the fatigue severity scale in patients with UARS and an apnea-hypopnea index of 4 is correlated with an R value of 0.53 very significantly with the stress level as measured by the Body Sensation Questionnaire. And that's fairly evident. Increasing stress, presumably related to flow limitation, increasing fatigue in a cross-sectional way. What I expected to see here in a group of 150 obstructive sleep apnea patients with a mean apnea-hypopnea index of 43 was I expected no relationship between stress and fatigue. I expected this to be entirely on the basis of sleep fragmentation, because we know sleep apnea is a disorder of sleep fragmentation. The problem is that these two graphs are identical. Identical regression equation, identical R value, identical look. In other words, I could have taken all 302 patients, thrown them into a big bag, pulled out 152, and I would have gotten this graph, put the 152 back in the bag, pulled it in and pulled out 100, and I would have gotten this graph. These are all the same patients. There's no such thing as a difference between obstructive sleep apnea and UARS. It's one disorder. And that's why I don't use the term UARS anymore, because it's all sleep apnea. And even in the patients where we think that flow limitation and sleep fragmentation, even in the patients with obstructive sleep apnea, in whom we think that sleep fragmentation and hypoxia and hypercapnia and God knows what else is responsible for their symptoms, the answer is no. Stress is responsible for their symptoms also. It's only
Although
one
everyone
disorder.
should check out the paper that I just put the link to in the chat, because some of what you just said, Dr. Gold, might be slightly conflicting with some of what you said in that paper about the different phenotypes of OSA, but I won't go too into that anyways. People can check it out.
Some of what I said in this, time out. Some of what I've said in this paper runs counter to the paper I just published.
Right.
And that's why I'm walking back this observation. I believe that the Epworth Sleepiness Scale was a legitimate tool until I showed that it wasn't. And now I have to go back, and that's what a good researcher does.
Yes.
When you find out
the evolution of science.
You evolve. I wouldn't trust these graphs anymore. Okay, going a little further. I'm almost done. So here is this is clinical data on 45 of the 152 patients who took and utilized nasal CPAP, and 49 of the obstructive sleep apnea patients who took and used nasal CPAP. And I'll focus you on the fatigue severity scale, which is in the center, and also on the body sensation questionnaire, right? That dropped, and this is a little too small for my eyes, but from the around 30, 31 in UARS to the mid-20s, 29 in obstructive sleep apnea, again to the mid-20s. These were highly significant changes in sympathetic tone with chronic nasal CPAP usage, right? This is just the BSQ questionnaires. And the fatigue severity scale dropped from 4.5 to 3.8, or 3.5, I believe.
4.5 to 3.5, yep.
Yeah. And again, in obstructive sleep apnea, it dropped. And again, I'm not paying attention to Epworth. So using CPAP chronically, and these are clinical patients, so they came back for follow-up, and it could be a number of months between these two measurements. But with chronic CPAP use, 94 patients with sleep-disordered breathing improved their stress level and their fatigue level. And here is the change in fatigue against the change in BSQ. And lo and behold, they're correlated with an R value of 0.32, and it was statistically significant. And the zeros are the UARS patients, the X's are the sleep apnea patients, and there are 94 data points here. So you've got change in stress causing a change in fatigue, or change in fatigue causing a change in stress. Have it any way you like.
Or a third piece causing change in both. So you've got a very, very strong correlation. And then it would be very interesting to see what other groups of patients studied on the body sensation questionnaire had what other responses to what other treatments. And
the third thing would be inspiratory airflow limitation, causing a change in both.
Yes, and so then, and those would all be specific examples of items associated with changes in airflow and breathing. Are there in the IBS literature? Are there people who had body sensation questionnaires and changed their microbiome? And would that do it? In the vascular parts, are there people who had the stenting in the iliac vessels or did something in their microvessels and had changes as well? And that may triangulate on this, in general, long COVID, for example, as we all know, is talked about as being a disease of potential viral or blood clot or metabolic or multiple combinations. And I think we're zeroing in the body sensation questionnaire. It seems to be very sensitive to the changes of improvements that if you ask a patient, hey, are you feeling better? Are you doing better? Is it working better? The answers are yes. And that's one of the key things is to find a measure that's sensitive to the change. And so this is great.
Sensitive and specific if you read the data really deeply as well, because you can sort of group sections of that questionnaire as well. I find it very valuable. I'll probably be using it.
So I'm going to end here, actually end this presentation with a summary slide. And my points are: fatigue is not the same thing as sleepiness. It reflects chronic stress and somatic arousal. Inspiratory airflow limitation during sleep is a hidden stressor in obstructive sleep apnea, fibromyalgia, and Gulf War illness. Nasal CPAP improves fatigue, pain, anxiety, and cognition, even when AHI is low. Somatic syndromes may be adaptive or maladaptive responses to chronic biological stress. And we must listen differently to the patient's voice, not just the polysomnogram. And that's my presentation.
Thank you.
Bravo. This is really enlightening. So let's see so should we're sitting at 2.5 hours, which is longer than we often go. But it's been a robust discussion. In terms of the questions that are sitting out, there's some questions about ME. Go ahead.
Can I ask a question, Dr.
Yeah, good.
So one, practically in the clinic, so patient comes in, has been evaluated at a sleep clinic, does not have sleep apnea. Maybe I can read the sleep study a little bit better now after this talk. Is there a way to bypass insurance and just have them cash pay something for a month to where they can trial a CPAP on their own or a nasal CPAP and sort of just, as we do with so many other things in this disease, and then if there is improvement, go back to insurance or the sleep clinic and so forth and make a case. But how are there resources? How affordable is it? Because oftentimes that's where the barriers are.
Right. So, I mean, I would question whether you're going to get anywhere treating them and then making a case to the sleep disorder center. You're not going to get them to change their diagnosis. And the insurance companies are not going to cover CPAP if the apnea-hypopnea index is less than 5. But that's not strictly true. The International Classification of Sleep Disorders, 3, counts respiratory effort-related arousals in the number 5 for diagnosis of sleep apnea. Most sleep disorder centers ignore that. I utilize it, and I'm able to get CPAP for the vast majority of my patients by counting RERAs. But I can't get it past Medicare. They require an apnea hypopnea index of 5. How much does it cost to rent the machine? You could probably rent it for $200-300 for a month and give it back. In fact, that's the way they usually start. The insurance company rents the CPAP unit from the company, and if the patient doesn't use it, they stop paying rent after 3 months. The machine, to buy it, new, would be closer to $1,000. Go ahead.
Would they start with the normal CPAP, and then if there's no response, then try a nasal?
No, you'd have to start with APAP because you have no basis for knowing how much pressure it's going to take. And too little or too much pressure is a problem. The other thing is you have to know how to use CPAP. A big problem, when I show you CPAP, CPAP is one of the most misprescribed treatments in medicine. Full face masks don't work, but they're used all the time. Pressure is over titrated. And but when a patient fails CPAP, it's not necessarily because they don't have sleep apnea. It may be because they were not prescribed CPAP properly. So therapeutic trials are difficult also with CPAP because patients take a while sometimes to get used to it, and some of them don't want to continue. So I feel
just
for
bring back that insurance question brought up because full face is often the only thing that's covered. Just terrible.
Yeah.
Do you, out of curiosity, is there, as you talk about one of the things that back at the beginning of the talk with anatomy and things, with the sort of limited size within the nares, is there any place where some of the things we see on sports fields and so on of like taping across the bridge of the nose, or things that people do to try and get a little bit of aerobic edge in sports that makes any difference in any of these patients, and especially is there anything else you could do short of CPAP that still might have some effect, even if not a perfect effect?
Yes, the answer is absolutely yes. And in fact, in children at the Stony Brook University Sleep Disorder Center, right after tonsillectomy, the next thing they get is a palate expander. Right? They get sent to an orthodontist, and they put a palate expander in their upper mouth, attach it to their maxillary arch of teeth, and they just widen their nasal passages. And in fact, I have a case report published of an 18-year-old with treatment-resistant adolescent depression who we diagnosed with upper airway resistance syndrome, put a palate expander in his mouth, and cured his depression.
Well, and especially in light of, the issue of EDS, of hypermobility was raised earlier. And especially in children, it makes sense that you can make those sorts of interventions fairly simply.
And we do that with adults too, with a surgically assisted palate expander. And we cure insomnia that way. But what we do more often, and I've also published a short case series of that in insomnia, we have a very good maxillofacial surgeon and they do at Stanford too, but we have a very good one at Stony Brook. And we take these patients with UARS and mild sleep apnea, particularly the young ones, and we perform maxillomandibular advancement and cure their fatigue and insomnia and basically cure all their symptoms. And then we never see them again. And I've done that. I've done that 20, 30 times.
And by bringing the mandible forward, is that an external process, or is that something? Are any of these
No,
things?
they actually split the ramus of the mandible and they slide it forward like a trombone.
Yep. And are there any postural things that potential? I'm just thinking, is there anything related to a collar that would give lift and forward push of the jawline, and just thinking through, are there non-invasive?
So there are you're aware there are oral appliances that do that.
No, I'm not aware of the specific details. It's fascinating.
Oh, okay.
Yeah.
Well, yeah, they make a plastic plate that exactly fits the upper teeth, and a plastic plate that exactly fits the lower teeth. And then in the Herbst appliance, they hook them together in such a way that they protrude the mandible.
Oh, interesting.
So the
you're
upper
putting
teeth
some
hold
forward
the
tension on the
mandible
lower
forward.
jaw. Yeah.
And that is very effective in patients with milder sleep apnea who don't tolerate CPAP.
Yeah.
Oh, what about the nasal dilators called the mute device? Very cheap. It's a little thing that holds your nose open that you insert.
They're worth what you pay for them. Yeah, they're not effective in treating sleep apnea or even upper airway resistance syndrome.
They make me more comfortable, but they might not help me sleep better.
Exactly. What they do is they pull the alley of the nose away from the turbinates when they're swollen, and they give you a little more room in there. But they don't even help professional athletes, but they make them feel a little better.
Right.
A few things. So I shared it in the chat, but I do have a thread with advice on how to titrate your CPAP machine yourself. Now, I don't know. I mean, you may not technically supposed to be doing this without without a doctor supervising you on it. But like Dr. Gold said, like most sleep doctors don't know or care anything about flow limitation. And if that's an important or the most important factor for most of us, then we kind of just have to do it ourselves for now. So one thing that was recommended.
Wait, let me interrupt
It's important
you
to
for one moment.
understand the methodology, no matter how you're going, because that way you can also know when you're working with a clinician or practitioner that you know that you can make appropriate adjustments that are going to be helpful, that aren't going to lead you down the wrong road. It's important to recognize quality.
Let me say one thing that is helpful, that will make a difference. If you have a diagnosis of sleep apnea and you don't trust the CPAP titration that's been done, if you get APAP, if you use APAP, the APAP protocols titrate flow limitation, and they do a pretty good job. They really do. Sometimes people don't tolerate going on APAP of 4 to 20, which is the whole spectrum. I get their apnea hypopnea index and I limit them to a narrower pressure range, trying to keep the pressure the machine is going to choose right in the middle. But even if you go 4 to 20, it's better than bad CPAP. It's better than CPAP by a full face mask. The algorithms that ResMed uses, the algorithm that they use, the algorithm that Philips used, and I think they're getting out of the CPAP business, but the algorithms for APAP are pretty good. And
okay,
that's what I would
good to
trust.
know. That's good to know, because I kind of thought that the auto titrating was mostly just the algorithms were set to mostly just eliminate apneas and hypopneas and not necessarily flow limitation. Although I will say that just from my time on the UARS subreddit and such, so a lot of people do seem to prefer a fixed pressure. I don't know if it's because the pressure variations or swings can wake people up when they're on APAP, but a lot of people do seem to prefer a fixed pressure. So I guess if you're going to use the advice in my thread, it has instructions on just using an SD card in your machine, and there's a program called Oscar Open Source CPAP Analysis Reporter, and you can look at your flow limitation and try to find the right pressures and stuff. If you are going to do that, I mean, it might just be a good idea to get permission in writing from your doctor that you have permission to do that yourself. And then I also I personally think that the nasal dilator thing that I tried actually did make a difference for me. But I mean, it made it before so I could tolerate before, because I had a palate expansion surgery before that. I mean, it made it easier to tolerate the CPAP machine when I had it's like a it's like a breathe right strip, but it's actually uses little magnets that you put on your nose, and then it's a metal band. So it's basically like a really powerful breathe right strip. But for me, I felt like it did make a noticeable difference in terms of being able to tolerate the CPAP or BiPAP in my case. Oh, and one more thing, Dr. Because people were talking about like renting a machine and stuff. Dr. Rama is licensed in a few different states, California, of course, but also Washington, Indiana, and Hawaii, at least when I talked to him about this before. That was last year or something. You can, check with him, but he can rent people CPAP and BiPAP machines and like send it in the mail, and you can send it back if it doesn't work for you.
I want to bring up one of the questions that Dr. Rama answered in the question and answer box about posture. He said if somebody asked if holding a phone and putting your chin down to talk on the phone would make things worse, and he said it was the opposite. It was the breathing problem would make your posture be worse and make you do that when you hold the phone. So I thought that was surprising. I mean, if I had thought about it a lot, of course it makes sense. If you're fatigued and you're this and that, you're not going to hold your head up, so you're going to have bad posture. But and I have the nasal dilator and the oral device, and it's sometimes very hard for me to tolerate the oral device, and so then I don't use it. I've never noticed that it helped me sleep better. If I had that motivation, I would definitely use it more. So maybe it's not the thing that I need. And the dentist kept changing what kind of device he would give me, and they would never really adjust them. So this is tricky business, getting everything all adjusted, whether it's a CPAP or the right thing or the oral thing, but work at it, because if you do get it right, it's going to be good.
And when if somebody has an acute infection and has inflamed upper respiratory tissues, they're going to have a different flow pattern than if they don't have inflamed tissues. And it could be if somebody's has some hurt things going on and holds more water, they could be. I mean, so the whole body is a dynamic state. So the detail of listening to the body is really important. And just as some people here are describing things working and some things not working, it may very well be working for somebody, but it's harder to measure that sometimes across a whole population at a point in time or over time, and that's where the personalization, the N=1 at scale, comes from.
Yeah, Kat and I were talking at a recent Remission Bio meeting about how do you track this feeling of your nose feeling full, but it's not stuffy, right? And so I actually added a symptom to my tracking software called nasal inflammation. And since I've been doing that, I'm noticing how much it varies every day. I guess it's MCAS or allergies, different exposures to different things. And I would imagine that's affecting how I'm sleeping.
Well,
One thing I was going to say I was just going to say really quick with the mandibular advancement devices, of course, it only moves your mandible forward. Like if you have a double jaw surgery or a maxillomandibular advancement that Dr. Gold was talking about, of course, they move the mandible and the maxilla forward. But I think I was reading some kind of systematic review of mandibular advancement devices, and they don't often always fully resolve even apneas and hypopneas. So a mandibular advancement device could fully resolve one person's sleep disordered breathing, but it could just make it a little bit better for someone else. And they may have, maybe you combine a mandibular advancement device with CPAP, so you don't need such a high pressure. You can use both. But of course, there's the issue with many people have, TMJ, and then with the mandibular advancement devices, that can exacerbate that or just cause that in the first place over time. So anyways, it's a whole trial and error process, and people may combine different things. But yeah, that was it.
Do you want to leave us, Dr. Tupper or Dr. Gold, leave us with any parting words? And this has been fascinating, and the question and answer has been, I think, really helpful, and seeing the data, seeing that real changes and significant changes in people's clinical course by finding the nuance of measurement of what's going on and the specifics of the intervention is exciting to see.
I guess I would aside from what I've said over the last 2 hours, I will say for anybody who is interested in the audience, and I don't solicit business, but I have patients as others do from all over the United States. And if somebody feels they can't get the help they need locally and want to come to Long Island, we can arrange that for a day and have your sleep study done and your CPAP prescription or APAP prescription written and get you home. So you should never really feel that there's no way that you can get help. It's available. It may take a little bit of initiative on your part.
Dr. Chad, is she still there, or she may have had to step away?
Dr. Chada left.
Yeah, okay, so she's gone. And then anyone else on the panel want to have some last comments?
I'm definitely going to have to re-listen to this recording, but I just caught bits and pieces. But I think I definitely would have had some commentary, some things I would have liked to chime in. But I hope there's another opportunity like this type of panel to discuss this topic in more detail. And if there, Natalie or anybody else has, information about an organization that is trying to, raise awareness and kind of bring more sleep physicians and medical professionals in general awareness on UARS. I think it's definitely fascinating. From my perspective as an autonomic neurologist, sleep neurologist, there's definitely overlap, and we talked about a lot of the pathophysiology, and I think that bears out. And I don't know if it was mentioned before, but I see a lot of patients with POTS, and that might fall into what Dr. Gold called the somatic syndromes.
It does.
Yeah. So hope there's another opportunity to have another discussion like this.
Yep, we will, and we'll keep it in mind and try and do it on a day when you're not sitting in labor and delivery. And it's just, I think we're all excited for you.
We're making progress. We're excited. Yeah.
All right. Ellie, do you want to wrap us up and then we'll just stop the recording?
Sure. Thanks everybody for coming. It's very likely that we'll revisit this topic in the future. Certainly, as Kat has chimed in and everybody's enthusiasm is clear. We love to bring together people who are thinking in different ways to help the patients have better lives and more quality of life. We're Renegade Research, renegade-research.org. Please sign up for our newsletter so you would get notification of any future events. And the recording will be up soon, but our person who does that is out sick today. So give us an extra couple of days maybe to get that out. And our next roundtable is next Friday, March 13th. Yes, Friday the 13th on hypercoagulability microclotting and blood issues, and we're having Doctors Rezia Pretorius, Dr. Jordan Vaughn, Dr. Douglas Kell, and Dr. Jill Schofield. So these are some well-known names in the microclotting and blood issues like antiphospholipid syndrome. So we hope you can come next Friday. And then on the 27th of March, we're having Dr. Zach Spiritos, a neurogastroenterologist, come talk about the gut-brain axis and when things go wrong. And he's also versed in all these other syndromes, and we can ask him all of our questions on how he sees it from his point of view and how he helps patients. He isn't a phenom on Instagram, so if you want to start following him there, he does educate physicians and patients alike with humor and music and in very short bits, and it's been very helpful. So we're looking forward to that. On March 17th, St. Patrick's Day, we have an X Space Live for anybody who wants to just hang out and talk about long COVID awareness issues for long COVID day / week. And that's about it. Thank you once again for coming, and we'll get more information out to you as we can. Bye-bye.
Thanks, everybody.
Bye.